Non-ST segment elevation, acute coronary syndrome presence with myocardial ischemia without persistent ST elevation. Patients typically report substernal chest discomfort radiating to the left arm, neck, or jaw. Atypical symptoms include dyspnea, epigastric discomfort, nausea, and weakness. These atypical presentations are more common in women, elderly, and diabetic patients. Physical examination may be normal unless ischemia is extensive. Findings may include diaphoresis, cool extremities, tachycardia, or hypotension. Electrocardiogram commonly shows ST depression or T-wave changes. Cardiac troponin levels are elevated in non-ST segment elevation myocardial infarction. A rising and falling pattern confirms myocardial necrosis. Coronary computed tomography angiography may help evaluate epicardial disease. Risk stratification is performed using TIMIG, RACE, and HEART scores. High-risk patients require early invasive management strategies. Pathophysiology involves rupture of a vulnerable atherosclerotic plaque. These plaques have thin fibrous caps and large lipid cores. Platelet aggregation and fibrin-rich thrombus formation led to partial occlusion. Eroded plaques form platelet-rich thrombi with neutrophil involvement. All patients should be admitted for monitoring and management. Continuous electrocardiogram monitoring is essential during the acute phase. Nitrates are given sublingually or intravenously to relieve ischemia. They should be avoided in hypotension or recent phosphodiesterase 5 inhibitor use. Beta blockers reduce heart rate and myocardial oxygen demand. They should be avoided in heart failure, shock, or bradycardia. Calcium channel blockers are used if symptoms persist or beta blockers are contraindicated. Morphine may be used for refractory chest pain. Angiotensin-converting enzyme inhibitors are used in left ventricular dysfunction. High-intensity statins are initiated early and continued long-term. Aspirin is given as an initial dose of 162 to 325 milligrams, followed by maintenance dosing. P2Y12 inhibitors such as clopidogrel or ticagrelor are added for dual antiplatelet therapy. Dual antiplatelet therapy is continued for 3 to 12 months depending on bleeding risk. Anticoagulants such as unfractionated heparin or enoxaparin are used during acute management. Dose adjustments are required based on age, renal function, and bleeding risk. Early invasive strategy includes coronary angiography within 48 hours for high-risk patients. A conservative strategy involves monitoring with selective intervention if ischemia persists. Radial artery access is preferred to reduce bleeding complications. Long-term management includes aggressive risk factor modification. Smoking cessation, weight control, and exercise are essential. Beta blockers, statins, and angiotensin-converting enzyme inhibitors are continued long-term. Sodium glucose cotransporter 2 inhibitors or glucagon-like peptide-1 receptor agonists are used in diabetics. Prinzmetal variant angina is caused by focal coronary artery spasm.